Good afternoon, good evening to, it's June 11th, 2025. And I wanted to thank you for again joining us for another Managing Survivorship session. This is somewhat of a collective discussion. What I wanted to do is take a few minutes and thank those people in the audience today here at the Dana-Farber. I want to also thank those people who are online, who visit us every month to learn more about how they can go about managing prostate cancer along their journeys. Our mission at PHEN is to eliminate the African American prostate cancer disparity. Education, through education and advocacy. But also we create the tools, the educational tools for all people to navigate along their prostate cancer journey. Next, I'd like to thank our sponsors and partners, which are very important. One, Amgen, Bayer, especially Dana-Farber, because they have consistently allowed us to have this venue each month to help decrease the disparity by educating our audience. So this session is a very important session because what we're going to understand and what you'll understand is that we're going to talk a little bit about things that are in the news. President Joe Biden's recent metastatic diagnosis, and not into the gossip, but just let's take a look at his journey that he's about to venture forth. And also bring to your attention that his late diagnosis, this advanced, not aggressive, but advanced stage of prostate cancer, metastatic, is our opportunity, PHEN, and our community to really galvanize and move this issue concerning screening forward nationally. We have the ability today to reshape screening if we choose. But there's something I wanted to talk to you about. When we think of metastatic cancer, the majority of people, if not all of us, thinks that your life is over. Because even when you looked at the messaging that was coming out of the White House, it was pray for me as if there was no hope or little hope. The reason why I put this gentleman up is this is DeWayne Charleston. He's from Texas. And he passed last week. He passed last week, but fought every day to live. He had prostate cancer. He was diagnosed with prostate cancer. And I always say be very careful about statistics, because the statistics say that if you're detected late, advanced disease that's moved throughout the body, that your life expectancy for 5 years is around 30%. Your life expectancy for 10 years is about 18%. But we really don't have an example of a person or what can happen after 10 years. And DeWayne Charleston is a person who I will explain how he lived 16 years with advanced stage prostate cancer. A little bit of his background. He's from Texas. I'm from Texas. We pledge the same fraternity, Alpha Phi Alpha. He was born on the campus where I went to college. And he was also a PHEN ambassador for the state of Texas. And the state is big, and DeWayne Charleston covered the state every single solitary day. In his life, in his journey, he was diagnosed in 2009. 2009, with advanced disease in his 40s. So look at what he shows you. One, he had to be in his 40s to be diagnosed. He wasn't screened. And when they caught it, it was in advanced stage, in a metastatic state. So, but he didn't give up working with his the academic center in Houston, MD Anderson. He fought every day, and I mean fought. He would get up every day and work out, hour and a half lifting weights. He would run bleachers, wind sprints with 35-pound weight sacks on his back because he wanted to live. But he just didn't live for himself. He lived to spread the message why it's important. Men's health is so important. So he wrote his memoirs, and then we came in contact with each other because I'm an alpha, he's an alpha, and he was in need of something other than the treatment that they were providing. So PHEN, we helped him get into a clinical trial and helped him get in 2 clinical trials that allowed him to move forward for another 3 or 4 years. Now, 3 or 4 years where he can fight. Now, a week before he died, he called me up on the phone and said, Keith, I got a guy who has prostate cancer. He needs help. That's a person that is extremely strong-willed. And even on his deathbed, he was trying to help people. Amen. So we're dedicating this session to him. Amen. So, what will we cover? We want you to understand metastatic hormone-sensitive prostate cancer. We want you to understand how we at PHEN think about screening and the screening guidelines that we follow, that we practice, and then we educate as many people as we possibly can. I'm going to take you through one of our portals, PHEN Path. These are the treatment strategies that everyone should be following. Not Black, not white. Any person with prostate cancer needs to be on our portal so they can get the best treatment that they can. And just to remind you that we have a survivorship toolkit. That survivorship toolkit is found in our PHEN TV portal. And we'll have some questions and answers, and then we will also have polls. I like to start with a review of the glossary terms. That's things that you need to know. You'll hear in this, but you can always go back to our presentations that are recorded on PHEN TV that will talk about, so you can understand the terms that you're going to hear when you speak with your healthcare providers. High volume versus low volume disease. Very important. High volume, greater than 4 bone lesions, or when they say visceral, that's in the tissue. So you can be in the tissue, like the liver, or in the bone. Okay. And depending on the number of how many of these, the volume of your disease will determine the intensity of, or the type of decision that you make. You'll hear about radioligand therapies. That's one of the drugs that DeWayne used that allowed him 2 additional years of life. PARP inhibitors. This is the new cutting edge technology, the 21st century, that targets cancer's weakness at the genetic level. Androgen deprivation therapy. androgen receptor inhibitors, okay? These block testosterone at the cancer receptor. Docetaxel, this is a chemotherapy agent. Doublet therapy is ADT plus one additional treatment, chemo or ARIs, the androgen receptor inhibitors. Triplet could be ADT, chemotherapy, the docetaxel, and ARI. And there's a concept called treatment intensification. And this is adding therapies on upfront to the ADT. So you start out with ADT, the simplest treatment option. And then you stack your treatments on top. So this is very interesting. President Biden's prostate cancer diagnosis. Let's just look at the key facts. He was diagnosed May 16th, 2025. He's 82. So there's an issue there. People stop screening. I'm not going to get into an argument about whether or not he should or should not. From a PHEN perspective, he should have been screening at 75. And then it was his decision, and depending on how long he anticipated to live, and we would anticipate he was going to be president, he's going to live more than 10 years. He needed to keep on screening, but we'll leave that alone. Now, hormone sensitive, which is MCSPC, S stands for sensitive, or MHSCP, okay? Now, and then we know that was his diagnosis. They originally came in and said, he has a diagnosis of Gleason 9, stage 4 or 5, grade group 4 or 5. And then the family comes out, the Biden family emphasizes transparency, a hope, and effective management. But one thing they need to say is that we're going to fight this. We're going to fight this DeWayne Charleston style because they want to live. This is a very important tool because if the President of the United States or the past President of the United States had this tool, I think he would have felt more comfortable about what the future has to hold, and his docs too, maybe. So when we think about your diagnosis, your first time you're diagnosed is your initial diagnosis. But what we've done is a couple of things. We want you to understand your risk level. So we created a tool called PHEN Path, it's a portal, and then it breaks down a pyramid that if you want to understand where you are in your disease journey, you have to understand or know your PSA. You need to understand what your biopsy results, your Gleason and grade group, and then your stage of cancer. We did know PSA, we know his biopsy results, and we know his cancer stage. But as we scroll down, it was a little bit more than that. In this risk level, the president was metastatic, and that is patients with the initial diagnosis of cancer that spread to distant parts of the body, metastatic. He had a Gleason grade group stage 4B. So I just wanted you to see that these tools exist. We want all of America, all of those people online to know that, because if the president, past president of the United States, message to the public was somewhat timid, then he didn't have the PHEN tool in front of him. So I'll stop sharing here. But remember, this tool, we keep everything simple, was phenpath.com. So what from the president and from what we learned, what are the treatment plans and takeaways for survivors? The majority of people, as we poll, 70% of the people in attendance are survivors or their caregivers. We know that. So what's interesting is this. When you have a metastatic disease, that means you haven't been treated the way he was diagnosed. He had never been treated before. So he's naive. untouched. So if that's the case, he had a significant amount of options in his tool chest. He could have used, he can use, depending on it, is ADT plus radiation, right? EBRT, and this is where you direct to the prostate tumor alone, and then you may add on abiraterone, apalutamide, or docetaxel, or enzalutamide, these treatment options. Or he can have ADT and a chemotherapy, plus one of the abiraterone, one of the 4 treatment options, novel hormone therapies that exist, or ADT plus one of the following by itself. So the only thing that we're saying here is this. There's a lot of stuff you can do. You're not going to die. The president is not going to die from prostate cancer tomorrow in 6 months, because he's starting his treatment with advanced stages. He has the ability to live 5 to 8 years, and even more because we have a role model, DeWayne Charleston, who lived 16 years with advanced prostate cancer and didn't have the same treatment options that we have available today. So this message is for all those folks out there who are being diagnosed, where there's a high percentage of Black men who are being diagnosed above other groups with advanced disease. Don't give up hope. Keep that little light alive. So what do we learn from the past 2 weeks from early detection and treatment intensification is going to save lives? We know that that's going to be the case. And Biden's highlight case highlights the need for timely PSA screening and a comprehensive care plan. So let's understand metastatic hormone sensitive. So this definition is metastatic, outside the prostate, hormone sensitive. That means that the treatment options that are available, like ADT or apalutamide or enzalutamide, abiraterone or darolutamide, they're still sensitive to that because they haven't been treated with that. And that's what's important. It's the sensitivity, hormone sensitivity. Now you can have other terms like metastatic down here, castration sensitive, or metastatic hormone sensitive. So those are the 2 terms you'll hear in this case. Why does it matter? And I'm up here, and everyone here is looking at me, why does it matter? Metastatic hormone sensitive prostate cancer is a serious diagnosis, but it is treatable. And every person out there needs to understand it's treatable. You have a specific window that you need to focus on. And what's interesting is this. I just showed you an example of combination therapies. What happens is a lot of times, a lot of folks in the United States are only getting one therapy. They're not combining them up. And that happens to Black, white, Hispanic, urban versus rural. So this is something that you need to be able to talk to your doctor about, to ask them whether or not you're using combinations of therapies. Matter of fact, just ask them if they're following NCCN guidelines. And this is kind of a little map to kind of get an idea, visual of the way it works. You get your diagnosis. A lot of people start on this monotherapy, but the intensification is where you have the ADT, the docetaxel, and a combination of radiation, EBRT, or one of the following therapies, abiraterone, apalutamide, or docetaxel, or 3 forms of treatment, not just one. So your take-home message is you want to have, if diagnosed with advanced prostate cancer, you just don't want to be on one. You want to look at the combinations of medicine, and you want to talk to your doctor about that. So when you are diagnosed with metastatic prostate cancer, advanced prostate cancer, hormone-sensitive prostate cancer, these are some questions. Are we following the latest NCCN AUA guidelines for metastatic disease? Would these advanced hormone therapies, these ARSI or docetaxel, improve my outlook? How soon can we start a novel hormone therapy if my PSA rises? And this is something that's very important. Don't wait until you have to take the drug, the new treatments. You need to see if there's any financial assistance or programs that are out there that cover these combinations. And lastly, ask them, do you qualify for a clinical trial? Because we know what kind of care you're going to get in a clinical trial. You're going to get the best possible care that you can in a clinical trial. Now, I know we're kind of going backwards, but we're talking about PSA screening, and we want to drive this point home. PHEN follows NCCN, and that is average men, no family history, no genetic background, no history of cancer in the family. Start screening, or having that discussion to begin screening at age 45. But if you have a genetic background, if you have African descent, you are high risk, and high risk needs to be screened, begin screening at 40. That's our stance. Now, let's move when to stop screening. So that was a very important point. It wasn't someone that said, you stop screening at 70. It is your decision based upon how long you're looking to live, how long you're anticipated to live, to whether or not you want to stop screening. And so NCCN guidelines say greater than 75 years of age. You're going to look at the PSA level, see how low it is. And then from there, you make the decision and how long you're anticipated to live. If you're 75, you're going to at least live 10 years. And the way this group is going right now, you might be in your 90s. But the point is, these are the criteria that you have to use when you're talking with your doctor, your clinician, about continued screening. It's a $150 test, $50 test. And you can't screen? It costs more money to get your teeth cleaned. So why not do something that's going to directly impact your life? So that's our stance. 75, if you do want to stop, we're suggesting that looking at the life expectancy of men in the United States, you might want to continue. And matter of fact, you might look at your ancestry. How long did your auntie, your uncle live? How long did your dad live? How long did your mom live? If they lived in their 90s, then I think you need to keep on screening. But that's my opinion. But we follow and believe in NCCN. Okay, we talked about this age 70, and you're not supposed to stop screening. Interesting, and this is a point that comes up that's always overlooked. Screening is also after you've been diagnosed and treated. That's monitoring for reoccurrence. And there's really, if you look at it, kind of broke it down this way. It's a regular PSA for the first 5 years, and we know it's a blood test. And for the first 5 years, we lean towards every 6 months. And I think the majority of people lean towards every 6 months. But some people may go every year. There's no strict stopping point. But again, based upon your life expectancy. And again, if you're concerned about what your life expectancy is, if you go to PHEN Path, you go into the initial diagnosis, you'll see areas where using the Social Security actuarial table, that you can determine how long the federal government anticipates you to live, not somebody on the corner, just federal government. And remember, when we talk about screening, this generalization, you can't follow that. It has to be individualized. Your quality of life, your genetic background, and what you feel comfortable with. Now, we move to these treatment options. Now, I just showed you PHEN Path. This is a very important tool because it follows NCCN guidelines. That's why it's important. The NCCN guidelines change, are updated at least every year. Some of these other organizations are out 4 years. The NCCN represents clinicians who get together from all over the country to vote on the treatment options that people should be using, your healthcare provider should be using. So I just wanted you to get a look at the homepage and just remember this couple walking down the path, you're on the right page. And I put the arrow for advanced hormone-sensitive cancer. That's the category that President Biden, that was DeWayne Charleston's original diagnosis. So next, I'm not going to go through the tool chest, but I want to tell you a tool chest for survivorship exists. And we would like everybody to go to PHEN TV. And we have different sections that will focus on managing side effects. You have side effects, fatigue, hot flashes, bone loss, sexual dysfunction. That's a side effect. And then you have this emotional and depression or anxiety component that nobody talks about. So we have topics, we have solutions that you can follow. You don't have to be at a meeting. You can play it. We're ever ready. We're always on. Our content is always available to everyone in the nation, really everyone in the world, since we have viewership in Taiwan, Russia, China. So just a high level, we have topics that talk about diet, exercise, and even bone health. Now, it is suggested that if you're a prostate cancer survivor, as a matter of fact, everybody probably, follow a Mediterranean style diet. Incorporate aerobic exercise and resistance exercises. And make sure you have adequate amount of calcium and vitamin D, especially people with darker complected skin, because they have a tendency to be vitamin D deficient, especially in the Northeast or in the North. And there's something else that I wanted to say about bone health. Real world evidence recently published at the beginning of this year, and we had a seminar about real world evidence last month, suggested that the majority of men who are on androgen deprivation therapies have never had a bone scan. That's part of the treatment options. Now, I think they attributed that bone scans associated with ladies who develop osteoporosis, but men develop osteoporosis too. Because I was 6'6", so not that now. So I don't know what happened to my bones, but I'm just gonna let you know. If you're on ADTs, androgen deprivation therapies, you need to talk to your doctor to find out when it's time for you to get your bone scan. This is another topic, emotional and mental health. Very important topic. We have information, we have a video on that, and excellent video from, the specialist from the Dana-Farber Cancer Institute. This is a very complicated topic, a very personal topic, because we do know that prostate cancer is a couple's disease. And that's very important to maintain the quality of life you want to have. Now, we want to stop there, but I want to tell you something. We talked about this before. If you go back to 2009, when DeWayne was diagnosed, there wasn't really a lot of things out there. Radiation, surgery, and androgen deprivation therapy, that first line of therapy. But what we want to say is this now, this is whole chest of treatment options. And I just want to tell you that one of them, just recently approved, was darolutamide. You saw that in the earlier slides. Now, it's called Nubeqa. It is an androgen receptor blocker. And what it does is kind of latches on to the receptor inside the prostate cell, so testosterone cannot turn the genes on that drives the cancer. What's nice about this, and again, this is publicly available information, all we're doing is abbreviating it so you have an idea, is that it has low brain penetration. And what this means is fewer mind-body side effects, fatigue, falls, seizures, but also maybe a very excellent drug if you have a very complicated medical history, dialysis, cardiovascular disease, that these things may also be affected. But this is a drug that is suggested that for complicated patients might be a good drug. And you take it by mouth twice a day. Okay. Now, another one, now this is not a new drug, but it's starting to move to the left or moving to more applications at earlier stages of diagnosis. Now, it's a radioligand therapy. And so what this is that it is a molecule that binds specifically to PSMA, which is prostate specific membrane antigen, the M. It's a protein that's found on the cancer cell. So now it binds to it and has a radioactive particle. So what it does do, once the radioactivity binds to the top of the cell, it goes inside and it kills the cell. Because in the past, it's almost like a Christmas tree. In the past, you could see the ornaments on the Christmas tree. They're big, they're large. The technology that was available allowed us to see just the big stuff. But now we have technology, it's like turning on the light on the Christmas tree where you see all those little small places where the cancer is located all over the body. You're not guessing anymore. And now these therapies go in and target all the cancers, locations, the majority of them. And what's happening is if you can use these drugs earlier, then your life expectancy is longer. So as more and more of these clinical trials get completed, the FDA approves it, and don't forget the NCCN will then update their information, which they've updated their information about this treatment option. You get a chance to use it. So, some key takeaways. MHSPC, metastatic hormone-sensitive prostate cancer, is a manageable disease. 2, when you're talking with your doctor, don't just stay with one treatment option. Ask about doublets or triplets of the combining the treatment options and have that discussion. And then when we talk about survivorship, like DeWayne Charleston, live well with a purpose. So, resources, phenpath.com, PHEN trials, you're looking for clinical trials. And last thing, which I didn't put the number up, but you all know, you can call us because we're on call for everybody. Now that I've bored you, I'm going to open the floor online and here at the Dana-Farber Cancer Institute for you to ask questions. Any questions? Yes, sir.
Does prostate cancer have any relationship to blood clot?
An interesting treatment options may influence blood clots. So your treatment options that you may have an indirect influence on them. But I'm not aware of a direct relationship between the cancer itself and developing blood clots. I think you'll get more blood clots if you get infected with COVID than with prostate cancer, because that's not something that normally people talk about. But again, see, if that's the case, having the complicated healthcare, having prostate cancer plus a blood thinner is something that if you had prostate cancer, or if you do have prostate cancer and you're under treatment, you may ask your doctor for another type of therapy. But to answer your question, I don't know, and I haven't come across anything that has said that. It may be out there.
How about if you use radiation as a treatment for treating the prostate?
Well, you can always have vascular injury, and then indirectly something like that can happen, but it's not what we would consider the common side effects associated with it. Erectile dysfunction, or let me reverse it, incontinence, those type of things that are associated with radiation treatment. Next.
Yes, hi. I have a question. Why do you guys follow the NCCN guideline instead of the American Urological Association? Is there a specific reason for that?
I mean, a couple of things is that the American National Cancer, NCCN, is made up of representatives from 26 of the top cancer centers in the United States. Okay. 2, they meet, vote on the best treatment, and they read the literature. And I'm not saying the AUA doesn't. They read the literature and they update more regularly. See, I don't want to wait 2 years. If you read it and you meet twice a year, then they'll vote quickly, and then that information will be updated. We need real-time information change. And from our perspective, and the fact that the president of Prostate Health Education Network, Tom Farrington, is on the panel, so he's in there talking, understanding what's going on, and being able to influence or give people a different perspective of a group that's marginalized, not overlooked. Our voice is in the room. So if our voice is in the room, I think we have an opportunity. That's the best resource for us.
I have a question. Is the double condition of stage 4 and Gleason 9 more critical?
Well, that's an interesting question. I don't understand, and maybe somebody could help me. Once you're diagnosed with metastatic castration-resistant, whether or not they know what your Gleason score is doesn't really matter anymore, because you're outside the prostate. So all the treatment options that are available change dramatically. You're not going to go in. I mean, well, I did mention that you could, if it was localized, you could use radiation and target the prostate cancer itself, and then around the bed, I mean, around in the pelvis area. But I question why they presented it that way, as if it was just localized. It's almost as if we just caught it. You just didn't catch it. It was all over the body. So you caught it late at a high risk. So then I question, people who who do not screen for the president of the United States. But go back to your question. That is, your treatment options change once the cancer is outside of the prostate and is classified as metastatic. And that's why that little arrow I was pointed to advanced hormone sensitive, because that's the stage. It's non-metastatic or metastatic advanced hormone sensitive. Next question.
Yes. After radiation treatment, 28 sessions and hormonal shot, PSA number was 2.7 after 1 year. Does that mean it's been recurring?
Well, and that's a very interesting point. You're going to have to distinguish between radiation and surgery. With surgery, you're looking at a PSA of like 0.2 to 0.2. You know that means that's that lowest it can be. That's the bottom. But radiation, the numbers can be high. The point is, for the person who asked the question is that now you're going to have to monitor it every 6 months. If you're after your treatment and you're still at 2, and then 6 months later you're still at 2, and then 6 months later you're still at 2, that may be the baseline. That's the lowest that you can possibly get. And that's why it's responsible, this person who asked the question, or if you know someone, to monitor your PSA every 6 months and continue monitoring. Because at any given time, it could pop and double. But then if you know when it doubles, then now what's the next treatment options that are available? Next question.
Yeah, I like what I'm hearing, but I got a concern that we need to get this information to more doctors, because like the president get diagnosed, and there are a lot of people who get diagnosed, they go to the doctor, and sometimes the doctor doesn't have this most recent information that you have. And then I give him a split, unless there's some person who knows him, to get the information. So could there be a plan so that you can target doctors so that they know what to tell their patients for this, give their patients this information?
Yes, there can be a plan. And we did a pilot project where we work with a healthcare center in Maryland. And we integrated a program where when the person was 40 years high risk, a flag would come up to alert, right, the doctor that this person is high risk. Now, what we did was create brochures. So the problem with the doc is busy. And the more information you can provide a doctor, and this is what you're kind of bringing up, the easier for him or her to educate the patient about what's needed. And then indirectly, you educate the doc. So yes, we have pilot programs that were extremely successful, where we had doc PSA and a poster that summarized when it's time for high risk Black men, high risk men to get treated, screened, and a little brochure that the patient can take home. And on that brochure, you have PHEN's telephone number, and you can call us up. Or you can go to the portal and then call us up. Yes. And it works. But-
That's good, because again, like you said, I know that it's just tough to get doctors to say, no, listen, so that's why I brought that question up is.
And then the question is if,
And
if the doc doesn't want to follow the guidelines, then you have that choice
Mhm.
to seek out another clinician.
Mhm.
Because it's your life. And you have to fight for your life if you want to live.
I have another question. If the cancer is still contained in the prostate, what will be a very less side effect treatment between radiation and robotics therapy, surgery?
I mean, you have treatment options. You want to watch and wait, active surveillance, or you're going to have surgery and radiation. Or what some people are doing is trying to go in and just carve out that area where the cancer is located. Those are treatment options that are available. But it's going to be up to you to decide on whether you want to wait for something to come up, and especially if you're a person of African descent or if you're a person that's high risk. Do you really want to wait? Because a lot of people are concerned about the side effects associated. But as we move and the earlier you detect it and treat it, the less chances you're going to have these type of side effects that people are having problems with. And then even if there is a side effect, and a lot of men, the majority of men are worried about sexual dysfunction, there's treatments for that. There are drugs that you take by mouth, there's injectables, and at the end of the day, you can also get an implant. It's not taboo. Insurance company will pay for it. Everybody else is using it. Implants have been in existence since the 80s, since I was in medical school.
Amen.
So live, and we can rehabilitate all the other stuff. But the objective is to get you to live an excellent quality of life. And then rehabilitate. Next.
Go ahead. My question is, Dr. Crawford, is should a person who has metastatic prostate cancer, should they pursue it and not, I guess, not waste the time because the time is short? Yet we see this gentleman who lasted 16 years. We know prostate cancer is slower than other cancers, and thank God for that. But we as Black men need to be continuing to be pursuing and persistent with our doctors, that they know the things that we know we need, they need to know what we need.
Right. That's an excellent question. And I go back to DeWayne Charleston. He was diagnosed with metastatic hormone-sensitive disease with limited treatment options. And because he controlled what he can control, diet, exercise, spirit, going to church, helping other people, doing the best he possibly can, because all the lives that he was meant to touch would have never been touched if he wasn't alive for the 16 years.
Amen.
So we have to control what we have to control. PHEN is here for you. We don't expect you to have all the information, but we're going to educate you. So when you go into the doctor's office, it's not Uncle Pookie, Dr. Google. These are guidelines that physicians should be following. And if they're not following these guidelines, then you have the right to find another doctor who will follow NCCN. So we have moved away from doctors telling you exactly what to do, managing you. They're your consultants. And if you're consultant, I want you to fix my house, cut my yard, plant something, you're gonna talk to them and figure out whether or not you want to use them or if they're talking the way you want them to talk. And if not, then you're gonna have to find someone else who's gonna fight for you to live.
What may cause prostate cancer?
You know, that's a question that always comes up, and I like the question because it's not a simple question. We know it has genetics, right? Because it's passed down. And if you want to look at ancestral slave trade, you'll see prostate cancer following the ancestral slave trade route. But also, there's the environment. See, the outside environment, whether it's something you eat or you're out in the sun or even stress,
Drink.
smoking. So these factors that can come into play, if you're prone to develop a cancer or develop prostate cancer, these factors may play a role. Depression, anxiety, something that suppresses your immune response, like stress, microaggression, driving in Boston traffic in the afternoon, at night. Stress and anxiety chronically can play a role. It's called multifactorial. So there are multiple factors that do it. Diet, lack of exercise. So what we need to do is control what we can control. Screen as early as possible, get the best treatment as early as possible, and try to create a quality of life better than what we did in the past. So Jerry, I think we can move on. Oh, there's one of the, two. Oh, let's take those two questions.
Just to follow up on that question that was just asked. So I was doing some research and they were saying that a family who has breast cancer can have like men who has like family that has breast cancer can have the chance to get increase for prostate cancer. In your perspective, is that correct or have you done research on it?
Matter of fact, we created a portal, which I didn't talk about,
That's
which is PHEN, PHEN for Precision Medicine, that talks about this topic of genetics. And so what the lady that was asking the question, it's if a mother has a history of breast cancer and she has a BRCA1, BRCA2 gene, people normally think she's going to pass that gene on to her daughter, but she may pass that gene on to her son.
okay.
So that gene plays a role in increased incidence of cancer. But what's good about that type of cancer with a genetic defect is a drug that I mentioned earlier in discussion called PARP inhibitors that target and prevent that cancer. It breaks the genes up, so it automatically goes to a death state. So the answer to your question is, mother can pass on genes to the son, increasing chances of getting prostate cancer. Fathers, if they have a BRCA gene, can pass it on to the daughters, increasing their chance. Because 50% of your genetic makeup, mine, was passed on to my children. So my son's at risk, and he will begin screening when he's 40. So Jerry, did you, any more questions before we pass the poll? There's one more.
I have a question.
Talk in the mic, please, sir.
Yes, I thought it was on. That's it, yeah. Okay. The question is this: I had prostate cancer. They removed the prostate.
Right.
Okay, and yet I'm being monitored.
Yes.
So there's no more prostate in there. So Are they monitoring because there might be some minute cancer cells that's floating out there someplace that become active that triggers prostate cancer? Because if the prostate is gone
Mm.
and they clear the margin, I'm being monitored. for
Good.
prostate.
So no,
Yeah.
I mean, it's an excellent question.
Better.
So I'm glad you brought it up because there's,
They take out the liver, you have cancer.
so when a surgeon is, and depending on how they did this, but when a surgeon is using robotic surgery to remove the prostate, they only remove what they see. So I give as an example. You cut a chicken on the table, got blood on the table. You wipe off the table. Are the bacteria that you can't see gone? No. The cancer cells are microscopic. And because they're microscopic, the only thing that the surgery can do is clear it. Now, what they're doing is this treatment option, this diagnostic option, where they're looking for the cancer cells, the proteins on it. So now we're moving into this new era where we can use this sophisticated technology to kind of see if there's any residual cancer cells. And if there are, what you're doing by screenings every 6 months is going to catch it early. Because that's what needs to be done. You can't see what you can't see. And you can't see a single cell or a million cells, a speck, by the visual eye or by a camera. So what they're doing is the best that they can do now. So now we're going to, I'm a little bit over the hour, but I really appreciate everyone taking the time to bear with me. And we put up the poll questions, and we want to get an idea of how well we did today. This is an important topic. It's complicated. We went over a lot of stuff. But our take-home message is this, is it's important to screen early. It's important to speak with people, whether it's your clergy or whether it's political leaders, how important this simple blood test is for men's health. In the state of Massachusetts, you can have a mammogram and you can have a colonoscopy, and that has no cost. But the same type of program doesn't exist for a simple blood test for prostate cancer. And so that's very important that you spread the word, talk, recognize how important it is. Talk to clergy, talk to your pastor, come on. Political leaders, you were in here talking about political leaders earlier, who you might have a voice with, who can help with this dilemma. And you know why it's so bad is because if you look at the data from American Cancer Society, between 2019 and 2025, the incidence of prostate cancer is increasing at an alarming rate of about 80% over those between 2019 and 2020. Now, I don't know if you had a chance, but we may send it out again, but Mr. Farrington wrote a press release, a blog about this problem and why it's so important for us to act now. It's not important to finger about the doc who didn't screen Biden, but if the president of the United States or the past president of the United States was overlooked, some people sneeze while other people get pneumonia. So that's important. You have a question?
I do, Dr. Crawford. Is there a way right now that council will stay together in terms of not being able to be closed off? I saw that op-ed that Tom had written, but I'm saying so that they'll still be looking out for servicing and helping people of color in terms of getting tested and following
Well, see, that's the one we want to be careful about, because those are the ones that didn't want, that saying you didn't want to test. What we need to do is, and what a lot of people don't recognize, Mr. Farrington has been in this fight since the late 2000s.
That's so,
He was able to get a resolution in front of the Senate about prostate cancer screening, couldn't get in front of the House. But this is a window in time. This is an opportunity that we need to exploit to see if we can do something about it. We can't do it by ourselves. We do our very best to bring it to everyone's attention, and we're going to lift what we can lift, but the tide raises all boats. So that means everybody is in this.
Amen.
Oh, yes.
Question. Under the Trump administration, where does the funding levels for Dana-Farber stand for PHEN with regards to moving forward?
Well, I can't answer that question. All I know is that the federal government doesn't fund PHEN. And so PHEN is independent and we fight.
Amen. Amen.
That's good to know. That's good to know because
Now, but Mr. Farron is on board of Dana-Farber also. I forgot to tell you that too. So again, how important it is to have someone from PHEN at key areas so he can weigh in, so we can constantly weigh in, so we become that squeaky wheel in the room. So that's what I can tell you what we can do. All that means is that the way I look at it is the more people that the present administration may impact or hurt, the more PHEN's needed. What I said before is, what have we always done since 1620? Troubleshoot, problem solve, and adapt. TPSA. Now, other folks maybe, but that's what we have to do. Jerry, how are we looking with those poll questions? Okay. Okay. Is there any other question? Jerry, did you have anything that come up online? I know there's a lot of them there, but. Yeah, while we're waiting.
Jack said he made 900 listening to his parents.
What are the treatment options when you become resistant to doublet therapy, ADT and enzalutamide?
Well, it's interesting you say that. The therapy that we talked about today, Pluvicto, which have originally it was hormone therapies have to fail. Then you go to a chemotherapy, and then you can try this radioligand therapy. But since the FDA has approved this, it's now moved so you don't have to go to chemotherapy. So if you fail on a next generation, apalutamide, enzalutamide, darolutamide, apalutamide, you fail on one of those, then you have the ability to go to this radioligand therapy. So it's moved up and when you can use it. And this is what I was talking about. Radioligand therapy is like these targeted radioactive missiles that only, or the majority of them, hone to the cancer itself and then deposits its radioactivity into it. So that is extremely exciting because if you can catch the current, I mean, it's very difficult to stop something when the momentum is going and the weight of the volume, I told you about low and high volume of the cancer has increased. What happens if these new therapies can be used at low volume? you have better success, longer life expectancy. That's fact. That's what the data is showing. So we're slowly and slowly, we get these clinical trials. Hmm? Okay. Okay. So we have our polls, you know. What happened? Oh, here we go. So the first question, do you know what factors, I think this is poll 2, okay. Do you know what factors shown on the risk level pyramid help determine your risk level? 64% said yes, 30% said somewhat, and 5% said no. So what we do is we want to make sure that everybody understands this risk level. So that means that we have more work to do. And so we'll have to swing back around and do a focus on understanding your risk level again and how important that is, because that's will determine what type of treatment options. Now, the second was, do you understand how your risk level determines your treatment options? 82% said yes, 18% said somewhat. Okay. Number 3, do you understand how your life expectancy estimate influences the available treatment options? 83% said yes. 17% said somewhat, and no one said no. Next one. Did you understand that did you understand the PHENtrials.com portal information presented? 69% said yes, 25% said somewhat, and 6% said no. So this year, we'll go back through and do a deep dive into the PHEN portal and PHEN trials. And we want people to understand it. And this is important. Next, did you find the patient story educational and inspirational? 81% said yes, and 17% said somewhat. Were you satisfied with the meeting and the presentation content? 88% said yes, 13% said somewhat. How do you rate the speakers? Well, thank you very much. 92% said very good, and 8% said good. So thank you. I still have to work, so I want 100%. Okay. Do you feel more confident managing survivorship challenges after this session? 77% said yes. 23% said somewhat. No one said no. That is good. And it's one thing, and if you have some problems, one thing you have is you recognize we're on call and you can call us and we will return your call within, if it's not the day, within 24 hours. How did you find out, how did you feel about the pace of the webinar? Too fast, 6%, just right, 92%. Next one, would you attend another survivorship focused session? 98% said yes, and somebody said no. Well, God still give us another chance. You know, we like 100% over here. Did the program allow adequate time for the audience? And the 71% said yes, 26% said somewhat, and 2% said no. And 81% of those in attendance were prostate cancer patients or survivors. 7% were patient survivor spouse or caregiver, and 5% medical professionals. 2% clergy, and some others at 5%. What that does is it wraps up this a June 11th, 2025 session, Managing Survivorship at the Dana-Farber Cancer Institute by Prostate Health Education Network. And there was one other thing. Happy Father's Day.
Happy.
Amen.